As I said at the outset, welcome to the info session for the West Virginia University DNP Nurse Anesthetist program. That's our official name. And I will share with you over the next 45 minutes or so just some pointers that give you an overview of the program. And we are a Doctor of Nursing Practice program, DNP. So that is the degree that you'll earn in preparation for a certification that's called Certified Registered Nurse Anesthetist. And then in whatever state you work in, you'll have licensure that's described by your state regulations and laws. So in the case of West Virginia, we are advanced practice registered nurses, and we also carry a registered nurse license. So that could be unique. But the degree from this program is a Doctor of Nursing Practice. The other option out there that you'll see from other programs is a Doctor of Nurse Anesthesia Practice. Those are typically hospital-based or non-nursing school-based programs. There might be some exceptions to that still, but largely you're going to see a DNP or DNAP. And the DNP is a nursing-specific degree. So our credit load, our credit total for the program is 88. And we'll look at the progression plan in detail. And it is a full-time hybrid curriculum, meaning a mix of distance education and face-to-face. And we'll get some detail about what classes are which. We are accredited. Our initial accreditation was effective October 9th, 2019. So if you do the math, we are due for accreditation this year, and we will have a visit October 16th and 17th of this October. So I've been in, and the faculty have been in preparation for this accreditation visit for some time. We've been writing a self-study for about 9 months, and I'm literally reviewing the final draft. There are like 8 categories of standards, and I'm through the first 3, and I'll be reviewing the final 5 today as a final read after I get off this call. So we're looking forward to the accreditation visit in October. And you guys are a member of the public that if you're in the West Virginia vicinity, Morgantown vicinity, you're welcome to come to a public reading of the report on October 17th at 1 p.m. So we've made that schedule already, and the visitors will read what their findings are. And you'll get a good idea at that point, are we going to be successful with our accreditation? So that's, we're looking forward to that. The Council on Accreditation of Nurse Anesthesia Educational Programs is the accrediting body that accredits and assures minimum standards for the education of nurse anesthetists in anesthesia educational programs across the United States. So they are the visitors who will be coming to look at our program on October 16th and 17th. Our cohorts are a maximum of 15 students per cohort. So this past fall marked the first time that we had 3 complete cohorts in the program at the same time. So a full complement of 45 students in our classroom seats. So we're excited to kind of reach that benchmark. And so that's the latest on the overview of the program. The faculty consist of 6 faculty members, including myself. Again, I'm Aaron Ostrowski. I'm the program director. I've been in practice since 2002, and I've been involved with SRNA education since 2008. Prior to that, I was involved with guest lecturing and whatnot at my alma mater, the University of Pittsburgh. So that's where I also taught from 2008 until 2017, and then left to build this program here at West Virginia University. To the right there is Dr. Kellen Smith. He is our assistant program director. He's a lecturer that has been involved with our program since 2021. He's been in practice since 2013. and he practices at Potomac Valley Hospital and another surgery center near Cumberland, Maryland. Dr. Mike Frame was our first assistant program director, and he still lectures in the program at a half-time FTE role, and he's been in practice since 2004 and been involved with SRNA education since 2017. Then Brenda Dean is our administrative associate. So any phone calls that kind of come to the School of Nursing in general generally get funneled through Brenda Dean. Dr. Laurel Miner is a lecturer that's been with us just since earlier this year. She came on board in March. She's been in practice since 1997 and been involved with SRNA education since 2018. Prior to that, she was involved in undergrad nursing education at Waynesburg University, and then she has an expertise in curriculum and evaluation. And then Dr. Angela Jeffries as a lecturer at our program, been here since 2022 and been in practice since 2001. So Dr. Jeffries and I graduated around the same time and have been in practice about the same amount. And she's been a clinical coordinator of student nurse anesthetists at CAMC in her actually current practice sites, and lectures here in many of our courses. So she's been a great help. One faculty member I do not have in the slides is Dr. Christine Cleaves. She's a nurse anesthetist that comes to us from far eastern West Virginia, really kind of where the Eastern Panhandle is tucked in between Pennsylvania and Virginia and Maryland. And she's also a nurse practitioner in acute care. So she brings a vast knowledge of diagnostics and whatnot. So she's a great asset to the program. Our curriculum is hybrid, meaning that there's a mix of online and face-to-face, as I said. 30 credits are online, and there are 36 credits face-to-face that are the nurse anesthesia specialty courses, 15 credits of clinical practicum, and 7 credits of DNP project courses. So something that could be unique that we'll kind of discuss a little later on is that we do build the DNP project courses specifically into the curriculum to allocate time for faculty and students to complete their project. The blocks, if you look at the heading actually down below in the footnote of the slide, these are the core DNP courses, meaning that these are courses designed to help students meet the essentials of nursing education in the graduate realm. And we do have these somewhat front-loaded so that you can be prepared to complete your DNP project. Courses that come in a little later can augment what's going on concurrently with your project, or can be preparing you for graduation as a professional. So these are the core DNP courses. The next, this next slide shows the nurse anesthesia specialty courses in these blocks. We do have an anesthesia course in each semester. So we introduce our students to the professional values right off the bat in Nursing 740A. And then from there on, prepare students for clinical entry in late semester 3. So we'll see that clinical semesters highlighted shortly. But these principles build from simple to complex. And so we start with foundations of anesthesia principles, basic principles, and combine that with a lab that prepares students for clinical entry with workshops on positioning and IV insertion and airway management and basic things to get a student started with their first anesthetics. We build on that from learning how to do a basic general anesthetic to incorporating regional anesthesia in the second semester, and start introducing advanced concepts in physiology, anatomy, and pathophysiology, and then advanced pharmacology. as you really hit the ground running in your year two, semester one, the first fall, I should say the second fall of the program, but that's where your first full clinical semester occurs. And then moving beyond that into advanced principles, in advanced principles one course, we talk about cardiothoracic, vascular, and neuroanesthesia management. Then in the semester three of the second year, the summer of year two, we introduce you to pediatrics, some obstetrics. Moving beyond that into the first semester of year three, we take the professional issues course from the first semester and now kind of look at what did you learn over the last basically 2 years of your experience as a student and a practitioner in the program, and what can we talk about in terms of professional issues. And then advanced principles 3 is management of special populations. This is where we have a peripheral nerve block workshop on utilizing cadavers. And so the real human tissue is very helpful to use ultrasound guidance and to have a deliberate and specific way to deliver anesthetic to nerve bundles and such. So it's a very good workshop. We have what could be somewhat unique. You could tell me if you've been shopping around to other programs, but the business management and finance and nurse anesthesia course is a course in which we try to take principles of business and management from our experts that are managers and have their own businesses in nurse anesthesia, and bring them into the course and share some principles of that with you. And then finally, we have an evidence-based anesthesia review course, and we are running that as we speak with our seniors, and we just allocate a bunch of time to assess what their needs are, what topics from the program do they want us to review. So we sent out a survey and they gave us some ideas. And so like tomorrow, or not tomorrow, but Monday, I'm presenting on the endocrine system and giving them a review on endocrine. Now, everybody knows endocrine, right? Like the back of your hand, right? So it's a tough system to remember. So we're going to kind of give them that tough topic literally for their last class in the program, and also give them a quiz on it to see how they do. And at this point, we have had, we require a threshold for them to score. So set a certain benchmark that we want them to achieve in the course to feel comfortable that they've reviewed and have mastered enough content that they can be successful on the national certification exam. It's not in our interest or the student's interest to graduate and not be prepared. So philosophically, we do feel like it's important to give the student the best opportunity to review all of the coursework and the anesthesia principles, and be prepared to certify soon after graduation, rather than fail and try to figure their way. Then the next set of courses involves a discussion about the DNP project. So the DNP project we call it an integrated. So because we do it, weave throughout the course, but it's somewhat of a parallel process, meaning it's not necessarily anesthesia specific, but it is an evaluation, it's evidence that you have risen to the level of doctoral study. And that's the deliverable that a DNP program has, say, analogous to a thesis, or someone in a PhD program completing their manuscript on research. In this case, you're preparing a manuscript on evidence-based practice. So we'll talk a little bit about that. Projects can be quality improvement, policy analysis, evaluation, and some others. Now, the vast majority of our projects are based in quality improvement, and there are certain models that we follow and such and guide you in that and how to implement the project. So the objectives for the project include assessing the practice environment. We help you with this part. Instead of having you come in with an idea that you kind of have to force upon your stakeholders, we give you ideas that we've explored with quality improvement teams in our partner institutions, especially WVU Health System, to see what they need. What are needs that your different stakeholders have that we could help with? And so with that problem idea in mind, you guys go to class and determine any variances from national benchmarks and look at what best evidence there can be to improve a certain problem that there is going on in practice. And it doesn't have to be anesthesia based. It can be any really health related problem. So the project objectives are to critically appraise the existing literature, design an initiative to address the practice problem. You'll seek approval from the school, your committee, of which I'm part of many of them. And we have many faculty throughout the school that are part of those teams. And then you also need to get approval from the host institution, namely the site of implementation. Then you implement the project, collect data, evaluate the outcomes, and write a manuscript to present the outcomes. Like, what did you come up with? And they can be changes for the better, or you can realize that, yeah, this really didn't work, and that's okay. That's part of learning, and that's what we are here about in this program. So you want to ask in your search for a school, what qualifies as a doctoral project? And I've already shared that with you. We have a lot of quality improvement projects. And one of probably the most perhaps involved projects we've had that's received some recognition is a student who completed an alert in the ICU from which he came prior to school. He worked with a nephrologist who wanted to develop an alert for acute kidney injury and let any prescribers know when they entered orders in Epic that medications that they were prescribing were going to put this patient at risk based on certain clinical parameters, and that there would be limits on the amount of time that this medication could be used or suggest alternatives. So that's an example of one of the doctoral projects that we've done. There are many others, but in the interest of time, I'll move on. So when does the doctoral project start? When does it finish? That's what you want to know. We try to start our projects for our students early, even before you really have some clinical knowledge of anesthesia, because we're not totally anesthesia focused. We do get evidence-based practice and a doctoral project development. The DNP project development course really is taken in the same semester that you start clinical. There's pros and cons to that, but I think the pros outweigh the cons, and that you can get your project done by semester 7 or 8 instead of worrying about it in semester 9 when you're really trying to focus on board preparation and getting your clinical hours. You want to ask how much time is dedicated in the curriculum to doctoral work. So I'll share that with you here shortly. And basically we have 7 credits devoted to it at this point. How our project idea is generated and vetted. I've already shared with you that we have project ideas that are ready to go, because I'll just share some principles that we give to our students when they're thinking about, like, do you really want to pursue this project? Is that, is it a project idea that the clinical site wants to take on? Can it be achieved? Can we somewhat take our time with implementing this project? We can't do a project that needs to be accomplished or changed in 6 weeks. In all likelihood, something that needs to be done that quickly wouldn't qualify as a project anyway, because it just isn't that rigorous. But we need a project that's going to take at least a year to kind of result, because you need to research the evidence, then implement and evaluate and figure out, is this going to work? So that's another piece. And then you want to have a clinical champion, someone that's in the clinical site that is willing to be your point of contact and a proponent, a someone who's going to advocate for you in the clinical realm. And then what is the advisory process? Is there a faculty member directly assigned with you? What is the structure of the team? How much approval red tape is there? And in our case, we're rather decentralized, meaning that your DNP faculty of record, which is our term for the advisor on the faculty level for the project, can really say yay or nay to the project, um, independently, but have consultation with other faculty if needed. So that's kind of our structure for the DNP project. So this is our allocation of credits throughout the program. At this point, we have the DNP project development taking place in the third semester after having had evidence-based practice methods and health statistics. Now we are looking at some shuffling of our curriculum that could move some courses around, but I'm not at liberty to share that just yet. But it's going to make, because we're just thinking about it, but it's going to make things more kind of contemporaneous. So we're kind of thinking about maybe moving statistics to be more just in time, say with DNP project development and semester 3 versus having it a couple semesters. Because I don't know about you, but if I take statistics, it's in my brain for the semester, then a couple weeks later, it's gone. It's not my forte. So we want to kind of give the student the best opportunity to mesh those things together. So we'll see. Stay tuned for that. But we do give the DNP project development course starting in the third semester. And then there are 3 semesters of DNP project implementation that give the student time to generally take a good draft of the proposal of the project from Nursing 830 to Nursing 831, where the proposal gets finalized and submitted to the IRB. Then the second semester of DNP project implementation is typically implementing the project, starting to collect data, and in the third credit of DNP project implementation is completing data collection and beginning to analyze data and kind of get all your ducks in a row for what could be DNP project presentation in fall of year 3, spring of year 3, or all the way to the final semester. But it gives the student flexibility to complete the project at a time that's convenient for them, that gives the option to continue clinical hours and starting review for the boards, or if there's some kind of delay in the project, the final semester option will not delay the student's graduation based on forces outside of the student's own interest in getting the project done. So sometimes just things happen. Clinical partners have some kind of delay. COVID happens, who knows? So anything can delay a project. The clinical commitment is what we'll look at next. The COA minimums at this time are 2,000 hours of clinical hour practice, 650 cases at a minimum, and programs should be able to demonstrate an 80% first-time pass rate for their graduates on the NCE. So the data that we have thus far include our nurse anesthesia classes of 2022 and 2024. Now, I can give you pretty much final information because everybody's done with clinical in the class that's going to graduate here on August 9th. So those totals are on the right side of the hash mark. But we don't have any, of course, pass rates for the class of 2024 yet, because they will not start to take their boards until after graduation. But the total clinical hours for the class of 22 was 2466. What I've been able to see just as of last night for the class of 24 is 2,275 hours. Now you can notice a drop there. I'll talk about that in a second. Cases, though, are basically equivalent. And then the other piece that I saw, 860 hours. Take a look at what other programs are getting, and they shouldn't be much less than that. I think we're right around the average numbers for programs across the country, maybe a little lower, but we're still kind of figuring out what works. Our Between the two cohorts of 2022 and 2024, the total anesthesia hours were much closer, a much tighter number. So I think I have it in the notes that the class of 2022 got 1,565 hours. And let me just end show for a moment. If you can see that 2022 got 1,565, class of 2024, 1,516. So about 50 hours of difference when you're looking at actual anesthesia time. So that, that's not a bad difference, not as drastic as you might think from looking at the difference in total clinical hours. And what the total means is basically the time that you show up in the morning for clinical to the time you leave. That's your clinical time till the time you leave the hospital. The anesthesia time, of course, is the time between anesthesia start and the anesthesia end for each case. And those are hard times. Like those get captured. There's no fluff in those. So those times are not bad. These are our clinical sites. There's a saying that I hear in West Virginia a lot. I'm not going to lie. The honest truth about this program is that the nature of West Virginia, its topography and its locations of population are dispersed. So travel is a part of this program, and but the upside of that is that we do have some remote locations that will give you CRNA only experience. We have a full quarter of our clinical sites are CRNA only. And they provide really a component of the full scope of practice of nurse anesthetists. So we do have practice sites in Maryland. So you see Cumberland located there. We have several locations in Pennsylvania. So we do attract applicants from Southwestern Pennsylvania. So there are options to rotate to sites up there for at least part of your rotations. And then we have locations in Parkersburg to the west, and Marietta and Camden Clark, Huntington in terms of Cabell and St. Mary's. That's a couple of great sites there. And if you kind of look to the south along the 79 Route 19 corridor, if you've ever headed to Myrtle Beach from the southwestern Pennsylvania or West Virginia area, you've probably gone along there and on your way to the beach or any other points south. Now so you see a host of sites along there. Our most southern location is Raleigh General in Beckley. And then we have locations out to the Eastern Panhandle in Berkeley Medical Center, which is in Martinsburg, and Jefferson Medical Center in Ranson, West Virginia. Okay. This is our kind of sequence or progression of clinical practicum courses. The courses are designed to require a minimum number of hours each semester. And if you total this up, you'll get to 2160. So as you can see, our students did, on average, reach that number and exceed it to almost 2,300. It is a program that requires a lot of your time. And so fitting in these hours is, a challenge, and a temptation is to do the minimum, but I always encourage students that, really clinical practice is where learning is applied and really is driven home. So points that we talk about in lecture, when you practice them, those get cemented into your brain through clinical practice. One thing I'll just highlight on here that has changed, you'll see kind of red marks through certain credits. We did shift credit allocations from the final summer to the final fall. At one point, Advanced Clinical Practicum 3 was 2 credits with 300 hours required. It's been increased to 3 credits for 450 because we have a ratio of 150 hours per clinical credit. And in the last semester, we reduced the clinical requirement to 300. And the reason we did that is if you look at the semester allocations at the top for the number of weeks, a traditional fall and spring semester is 15 weeks, but in reality, our clinical courses follow a non-standard session in the fall and spring of 19 weeks to allow more time for clinical practice. So you can actually have a couple of weeks each semester of clinical that do not include classwork. And those are times when I encourage students to really kind of get some extra hours that can make the difference between reaching your minimums each semester and getting a better clinical education. And then the reason that the summer weeks were reduced to 300 is because they're 12 weeks in length, and whether it's a clinical practicum or a didactic course, 12 weeks is a compressed period of time to get 450 hours of time. So we kind of made that proportion equal across the semesters. In terms of simulation, we prepare you for clinical by doing either workshops or simulations before you get to the point of implementing these things clinically. So simulation is weaved throughout the curriculum, an estimated about 65 hours per student. And so the idea, again, is to practice these critical skills before patient contact and to learn high stakes principles in a safe environment where if there's an unsuccessful outcome or you just do something the wrong way, we can correct it there without injuring a person. So I think that we're all familiar with the value of simulation. At this point, if you've gone through your nursing program, I'm sure you've done some workshops and simulation type activities to prepare for a skill. So nursing 743 would be our basic principles series of workshops, and you can see we kind of build from simple to complex, where we teach you about pieces of the puzzle, so to speak, of an anesthetic, and then go through a mock anesthetic induction where you go through a simulated induction of anesthesia, which is going to sleep, and address a minor complication or response to anesthesia that typically occurs after going to sleep. Then regional anesthesia is acquired in 742B, as I said. So we have an epidural and spinal workshop in this second basic principles course. Then perioperative assessment and care is a series of workshops and lectures that prepare students for POCUS, which is point of care ultrasound, and central venous cannulation with ultrasound, an advanced airway workshop, and then an advanced principle simulation where we might look at some, say, endocrine principles and how does the patient clinically present when they have hyper or hypothyroidism or some other derangement of the endocrine system. The management across the lifespan course, again, deals with pediatric and OB. And so we do pediatric and obstetric simulations. And then management of special populations, we talk about patients with difficult airways. That's where we also have the pain management cadaver workshop, where you learn peripheral nerve blocks. And then we go through a senior simulation dealing with crises that are rare but can occur in clinical practice. One scenario was a power outage where the anesthesia cath machine, the lights in the OR, everything goes out. And what do you do? And a graduate from the class of 2022 shared with me that they had a power outage in the first couple of weeks after graduation, and she started practice. So things happen. So these are examples of simulations that occur. This would be on the left, a mock induction that we did in the first semester, or first semester of clinical practice, preparing for clinical. On the right is our ultrasound guided central venous cannulation. So that's on a trainer. These are members of the first cohort that graduated from WVU. We do encourage professional meetings, attendance. So we have state level and national level meetings that students can attend. So we do encourage professional involvement. Now, this is where it's been all rainbows and unicorns up to this point, but you do have to talk brass tacks at some point, and there is a cost to this. So you can see a resident versus non-resident illustration of tuition. So you can see the breakdown of university tuition and health sciences center tuition. So there is a difference between the two, and you can see the difference there. That university tuition is really the biggest difference between the two. And in setting up this program, I had an influence on the amount of tuition charged at the HSC. Now, the HSC tuition is somewhere between a medical degree tuition, which would be higher, and a pharmacy, PA type of tuition, which is in the same ballpark. So in order to attract and maintain and retain high level and experienced faculty who are clinically practicing and engaged in the latest and greatest of nurse anesthesia, we needed to have some revenue that was going to be able to support that type of practitioner. And as you may know, clinical salaries are pretty high these days. So even with what we can offer our faculty, it can still be a challenge to keep up with the market rate. So that's kind of the rationale for what you see in terms of cost. But tuition for 9 semesters works out to be about $114,000 for residents and about $195,000 for non-residents. Then you add in the fees, which you can see is broken down through that covers all 9 semesters. The total can work out to be $130,000 for residents and over $200,000, $212,000 for non-residents. So you can take if you have any questions about this, we can take another look at this later. I do put an asterisk next to the C, which stands for self-evaluation exam. This is one of the exams that we can accept as a threshold score in preparation for graduation. So students, we require it once in late second year to kind of assess where the student is in their review, but they can elect to repeat the C in the last semester. Time commitment is another big piece. So clinical time, if you look at roughly 2,000 hours over 6+ semesters, where that's roughly a half of an FTE, because if you're doing that over basically 2 years, you're working half time, right? Because 2080 is a full-time job in 1 year. So that's a half FTE. Clinical preparation takes 1 to 2 hours per night. Class time is 1 clock hour per credit hour per week. So if you have a 3-credit course, you're expected to be in class for 3 hours for the week. So that could be 8 to 12, depending on the semester. So you just need to look at the credit total for the semester to come up with that. And that would be basically a quarter of an FTE. And then the bulk of work in doctoral study comes from you spending time outside of class, either reading, writing, studying, and that could be another half to a full-time job. And so if you put all of that together, adding up the maximum potential FTEs, 1.75 could be what it's like. So the question is, can we really think about as students being gainfully employed as you are now during school? That's what you have to think about. So admissions criteria, a lot of people ask about this. We've really tried to simplify things since we started the program. You need to be eligible for admission to the university, meaning the WVU at large. That usually means coming from an accredited institution. If you have any questions about that, we can talk about that. That's different from coming from a degree program that was also accredited. So there's two accreditations that we look at. A minimum GPA of 3.0 on a 4.0 scale. That would be in both, we categorize nursing courses in one group and everything else in another column. And you need to have a 3.0 in both groups of courses to be eligible. If there's less than a 3.0 in either one of those categories, we really don't process the application any further. Critical care experience, 1 year is required, but we prefer 2 to 3 years. And our cohorts have been averaging about 3.5 to 4 years of experience in the folks that have been admitted. And then regarding GPAs, our GPAs are around 3.5 or 3.6 on average. We require BLS and ACLS on admission, and then we require PALS by the in the interval between starting the program and clinical entry. That's a newer admission qualification. We just try to, if you don't have PALS, we're not going to sweat it. We can get that. You can get that later. We ask for 3 recommendations from people that know you, and we'll give you a good recommendation. Essay, I find that people don't take the time to really look at the STEM that we're giving them to write the essay and have someone proofread it. So, it's a pretty easy prompt to follow. You just have to touch on those points and be somewhat insightful about yourself. Then we, based on looking at all of that data pre-interview, we will put that together and interview the top candidates. And we typically look at, we have a goal roughly of interviewing about 3 candidates for each spot that we have. So, roughly 40 to 45 interview candidates per year. And then you need to be eligible for an unrestricted or unencumbered RN license in West Virginia. We're happy to accept multi-state licenses because West Virginia is a member of the Nurse Licensure Compact. Pennsylvania might be actually getting in the game finally with a full licensure partnership. I'm just not sure when that's going to be taking complete effect, but there is some partial implementation of the Nurse Licensure Compact from Pennsylvania as well. The admissions process, you may be aware of this already, but applications open August 1st, so later this week. They close November 1st. Applications are screened for completion. A call for scheduling an interview should hopefully happen sometime in December, and then interviews in January. Those interviews include Zoom interviews with faculty, and you also meet the members of the current cohort that basically answer any questions that you have and give some ideas. We offer tours at the School of Nursing and the Health Sciences Center. If you get an opportunity to come, I'll be happy to take you on a tour. And if I can't do it personally, there'll be someone like Philip Engelmeyer, who's on our website, that can tour with you, and I can be part of the meeting at some point. And then decisions are generally given by February. If we can get meetings sooner in January and our missions committee meets, I'm not one to be patient. I like to give a call as soon as I can, but we can certainly promise a decision by February. All right. And what makes WVU different? We have reduced our barriers to admissions over the years. So again, we don't require GRE. We don't really have any course prerequisites anymore. And we offer you the opportunity to get PALS after admission, but before starting clinical activities. We have smaller cohorts, so we can pay closer attention to you, which can be good or bad. And if you do what we ask of you, you'll be a rock star. If you want to buck the trend, we'll know about it. So, pros and cons of smaller cohorts. Passionate faculty, yes. And so we care about our students, and we are interested in their success. Early DNP work with high mentor to student ratio. So we have just a few students per faculty that we pay attention to and mentor through the project. So that's a plus, and we do give you the opportunity to practice to your full scope of practice and through the clinical training that we provide. So those are my high points to leave with you as we conclude this presentation. So I'm happy to entertain any questions. I will stop the recording at this point. So let me do that first, and then I'd be happy to entertain any questions. And the